In this image, we're looking at a frontal chest radiograph of a skeletally mature patient. The most striking feature here is a large, well-defined, rounded opacity in the right lower zone. This lesion has a thick wall and is located over the right inferior hilum, showing central cavitation. If you take a closer look, you'll notice the irregular margins of the cavity and the presence of an air fluid level within, which are key findings. There's no evidence of bony destruction in relation to this lesion or elsewhere on the radiograph, which is crucial to note. Additionally, there's some airspace opacification medially to the lesion, but no other focal lung lesions are observed. The hyla appear normal without enlargement. When I encounter such a finding, my immediate next step is to review any available previous imaging for comparison. This helps in understanding whether the finding is new or stable, which significantly influences the differential diagnosis. Given the appearance of the lesion, particularly the thick wall and air fluid level, I'm concerned about a cavitating lung neoplasm, possibly a bronchogenic carcinoma. This finding warrants urgent further investigation, including a referral to a respiratory specialist for bronchoscopy and a staging CT scan. When dealing with cavitating lung lesions, I always consider the air crescent sign, which might indicate infection or malignancy, though it's more common in bronchogenic carcinoma. The thickness of the cavity wall is also a critical detail. Thin-walled lesions are typically benign, while those thicker than 16 millimeters often suggest malignancy. It's also important to note any irregularities or spiculations in the margins of the cavity, as these can also indicate a malignant process. In the context of differential diagnosis, the possibilities vary based on whether the lesions are solitary or multiple. For solitary lesions, we think of bronchogenic carcinoma, infections like tuberculosis or bacterial abscesses, or infarcted lung cysts. For multiple lesions, metastases, septic emboli, or granulomatous diseases come to mind. The concept of cavitating tumors is broad, and while many types of tumors can cavitate, the morphology of the cavity wall can often help us assess the likelihood of malignancy. Primary cavitating lung cancers, especially squamous cell carcinoma, generally have a worse prognosis when cavitation is present. However, it's worth noting that the presence of cavitation typically rules out small cell carcinoma as a diagnosis, as small cell lung cancer rarely cavitates. So in summary, this case is a complex and critical one, highlighting the importance of a thorough and methodical approach in radiology. Whether you are a radiologist or a student, understanding these nuances can significantly impact patient outcomes. For more in-depth radiology discussions and cases, don't forget to subscribe to Radiology Made Easy. Your learning journey continues here.